So, welcome to the webinar utilizing the digital denture workflow in your practice. It is being presented by Tremaine Watkins, CDD, and we will begin shortly. And with that, it is my honor to introduce Tremaine Watkins. He is NDX's Clinical Director of Guided Surgery on Implant Solutions. Tremaine has been working in the dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington, as valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on the implant-supported and retained restorations. He also has provided clinical support for case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technology and has written and lectured on several aspects of restorative dentistry. And now I get to say, take it away, Tremaine.
Thank you very much, Jessica. I appreciate it. Very kind introduction. Thank you, everybody, for joining in. I hope you'll find this interesting tonight and get some pearls that will be helpful in your own practice. I have a couple housekeeping slides too. The first thing is my presenter disclosure. I am a full-time employee of National Dentex Corporation and have received financial support as an employee related to content of the presentation this evening. However, I have not received any commercial support from vendors or anything like that. So we got that out of the way. So let's talk about the need for dentures. I used American College of Prosthodontics statistics. I feel like those are, most people would consider them very reliable. Oftentimes they tend to be a little bit conservative based on the range of information I see out there. So I think that we can see these as kind of minimum of what's out there. So we're talking about, I mean, you can read the slide. You got 35 million people that are edentulous in at least one arch. Most of them have a denture. 15% of dentures are replaced every year. And I think this is critical. 81% of patients are dissatisfied with their dentures, meaning that as denture patients come into your practice, you can assume that the majority of them would be served and would actually like a new denture. Like we'll talk about in a minute, I think it's economic and reasons that kind of prevent us from serving this population. But on average, if you work out the numbers, there's about 174 edentulous people for every general dentist in the United States. So statistically, you have quite a few of these patients that are in your practice footprint, I guess you could say. So right now, there's 7.83 million arches of dentures replaced per year. That's a lot. But if you look at the 81% number, 42 million have the potential for replacement because the patients are dissatisfied. You know that your dentures should be replaced at least every 5 years. And I think the statistics I've seen is that it's closer to 10 when it really happens. And to just kind of put those numbers in perspective, there's all across the US, we have about 2.3 million single implant crowns restored every year and 31 million single, like number 3 FCZ type of crowns. So this is a very, very significant amount of potential business that I think oftentimes is kind of passing us by. And we'll talk about the reasons for that. So I want to talk about some fundamentals of dentures first. We'll kind of talk about fundamentals of dentures, and then we'll talk about analog dentures, and we'll talk about digital dentures using analog as a reference point. I think one of the things that's really important is that your dental technicians know a lot about materials and fabrication techniques and things like that, and even how to evaluate the records that they get. But many of them might not have your advanced knowledge of anatomy and function and things like that. So I kind of want to talk about this partly as a way to kind of, refresh the stuff from dental school, partly to encourage you guys to be a resource for your technicians. I know in the past, technicians and dentists, we sometimes seem to have a little bit of an adversarial relationship, but in truth, we're working together. We're stuck with each other more or less. And I think that when each of us brings all that we have to the table, our patients only benefit from that. As you guys know, occlusal scheme is critical with dentures because of the profound effect it has on denture stability. I mean, you guys know that when a patient comes in with dentures and they're not happy with their denture, it's going to be primarily because it doesn't fit well, it's unstable, can't chew with it, can't talk with it, falls out. So we're going to want to talk about occlusion and tooth position, both, just to refresh, like you can put teeth anywhere with a denture, so we need to know where to put them, but also so we can kind of look at how do we position the teeth well to create the stability that our patient needs. We're going to define occlusion as the way that the teeth come together in a static position, like when we're swallowing. And then we're going to refer to articulation as the dynamic tooth relationship while chewing. As you guys know, edentulous and dentate patients articulate differently. Denture wearers tend to chew horizontally with only a slight vertical component, and dentate patients have that warped teardrop pattern with much more vertical movement. Because of this different articulation, we'll find that denture teeth need to be set differently, again, to get that stability that our patients need. The thing is that even if we get perfect fit in our dentures, if we don't have the correct occlusal scheme, the forces that our patients are generating by chewing will be so much it'll overcome that stability and still make a good fitting denture unstable. So, as I'm sure you guys know, this is not going to be news to you, that occlusion on dentures has been a little bit of a controversial subject. Historically, I would say bilateral balanced occlusion, in which all the posterior teeth contact on cusp ridges and all possible movements, has been seen as the gold standard of denture occlusion. Problem with this is it's very difficult to achieve in real life. I saw a study once, and it's like, I think it was 1 in a million that could actually, when it was set carefully in balanced occlusion, it went in the patient's mouth and they tested it, where actual full bilateral balance happened. Oftentimes, because of differences between the articulator and the mouth, we wind up with prematurities in different areas, causing instability again in our prosthetics. I would say lingualized occlusion has become more popular in recent years because of this. Studies are consistently showing that these occlusal schemes have similar chewing efficiency, but lingualized occlusion tends to feel more stable to the patients when they're actually functioning. You can use either scheme for patients with a substantial ridge. It's definitely best to use lingualized occlusion for patients with severe ridge atrophy. A lot of times, the way that a posterior tooth is classified is by the cusp angle of the occlusion of the teeth relative to a flat plane. So this angle relative to this flat plane right here. Posterior teeth are offered in a variety of these angles, but the most common are 0, 10, 20, 22, 33, and 40. Teeth with larger angles tend to look more aesthetic. But with the aforementioned flat chewing motion common to most denture wearers, these teeth with high cusp angles, especially if they oppose each other, can create excessive lateral interferences, lead to tipping. And it's best to use 22 degrees or less on your full dentures. If we're designing a bilateral balanced occlusion for a hypothetical case, we'd set 22-degree teeth on both the maxilla and the mandible. However, for lingualized occlusion, we'd use a 22-degree tooth on the maxilla with a 10-degree tooth in the mandible. So A shows balanced occlusion and the slide, and B shows your lingualized occlusion. You'll need to decide what scheme is best for your patients, and this is a good example of something that you can help your labs by explaining to them which one you like. So next, let's talk about how we position the maxillary anterior teeth. Just like any of our patients, our denture patients are very concerned about the aesthetics of their denture, and we're going to want to get the teeth in the right position to give that nice look. I mean, we'll set the lower anteriors to get proper function. We'll talk about that in the next slide, but oftentimes when we're setting the maxillary anteriors, as much as possible, we're going to try to get them so that the case looks nice for our patients. So we want 1 to 2 millimeters of incisal edge display at rest on the teeth, no more than 2 millimeters of gingival display at Duchenne smile, and sometimes with denture patients, it might be nicer because that's plastic, to just show the teeth themselves. We want the incisal edge of the lower incisors aligned incisally with the lower lip, with the lip relaxed. Obviously, we want to set the dental midline parallel to the facial midline, the incisal angle parallel to the interpupillary line, and then proper lip support. As a rule of thumb, you can go 8 to 10 millimeters anterior to the center of the incisive papilla and get a pretty reliable position. But you'll also want to, when you're doing your try-in, you have your patient do fricatives and make sure that they're in the incisal edge of their maxillary teeth is touching the wet dry line. So we got our upper teeth in the right position. How do we set our lower teeth? So in general, with our complete dentures, we don't want the anterior teeth to touch in centric. We want them to contact when our patients start moving. So we get the best results with denture teeth if we set our overbite and our overjet to the same measurement. 1 by 1, as you guys know, is kind of a common measurement that seems to work well. But if you have a very mobile class 2, you may want a little bit more, and a class 3 with limited articulation, you may want to tighten that up a little bit. So definitely one of the things you want to look at when you're evaluating your try-ins is how are the anterior teeth contacting, again, with an eye towards a tripod. We want to make sure that posterior teeth and anterior teeth are all contacting so that the occlusal force is holding my dentures basically nice and stable in the mouth. So then we get to our posterior teeth. If our anterior tooth position is determined by aesthetics modified by function, our posterior tooth position really needs to be dictated exclusively by function. First, we have to set our posterior teeth over the crest of the ridge. Because of the occlusal force back there, if we get them off the ridge, we're creating a lever so that the patient can tempt their denture. So the Angles classification of a denture case should be dictated by the ridge relationship. In other words, if the ridges are class 3, we need to set the teeth in class 3, or we'll have unstable prostheses. If we move the teeth far off the ridge for aesthetics, we need to keep in mind that we're trading functional stability for that, and make sure that we talk to our patients. In general, we want to get those teeth over the ridge. We also want to make sure we get our occlusal plane in the correct position. What's really important for this, from a clinical perspective, is capturing the retromolar pads, because as you know, the vertical midpoint of the retromolar pads is the posterior indicator of the occlusal plane. And the position of the mandibular posterior teeth is especially important. We want their central dissectional groove and thus the maxillary lingual cusp centered on the mandibular alveolar ridge. We want to make sure that we keep our lingual cusp from extending past the mylohyoid ridge to allow adequate tongue space. These are things that you can kind of look at when you get the setups in your office, and just kind of, if you're seeing inconsistencies in this area, this can be a way that you can kind of help your laboratory and kind of talk about, if we work together on this, we'll get a much better result. And these are things that are true of digital dentures or analog dentures. We don't want any teeth in the mandible past the anterior border of the retromolar pad. Sometimes we can only do 3 posterior teeth on the mandibular side. Otherwise, we tend to get weird interferences in protrusion especially. We don't want to put teeth over the tuberosity, but it is nice to get 4 posterior teeth on the maxilla, because that helps hold the cheeks out so our patients don't have problems with their cheek biting. So we want to make sure that I'm using balanced occlusion here in a different way than I was previously. What I mean in this case is we want to make sure that as the dentures are moving, we're having contact on a tripod, posterior and anterior, so that we're not generating tipping force in any reasonable movement that the person's doing. If your patients have flat ridges, again, we'll want to use lingualized occlusion and also flat plane for class 3 patients. I want to take a minute to talk about denture borders, because they're so important for stability. And again, they're one of those things that you guys know backwards and forwards, because you see the movable tissue and you see the stable tissue. On the model, it all looks pretty stable. So our technicians are trained to recognize different landmarks. but sometimes you can help. And the other thing is when you're looking at your casts or your impressions, you can kind of say, hey, did I pick up all these landmarks? And if you didn't, you may want to take another impression just to make sure that you're providing your lab with enough information. So a couple questions. I think one of the questions is, why do we do a 5-year replacement for dentures? And I think it's just because we tend to get enough resorption to where we're not getting a stable fit. Obviously, you guys will want to evaluate that clinically, but that's kind of the guideline I've seen out there. And the tripod, I realize it's a little bit unclear the way I said that. What I meant was that in centric, you're not contacting, but as soon as you start moving, you want the teeth to, the anterior teeth and the posterior teeth to contact. So good questions. Thank you very much. So we want to use as big of borders as we can to help cut down on ridge resorption by dissipating occlusal force and get as much stability for our patients as possible without contacting mobile tissues that are going to tend to create sore spots and potential dislodgement of the dentures. So when we're doing our maxillary dentures, we want to make sure we capture the hamular notch so we can extend the denture over the tuberosity onto the hamular notch. We want to stay 1 millimeter above the floor of the vestibule, avoiding the frena on the buccal. And then the palate, we want to extend to the vibrating line. Sometimes that can be a little bit difficult to see on the model. So if you mark it either on the model or on the impression, it will, to where it picks up on the model, that'll really help us so that we get the exact right spot for that. For our mandibular dentures, we want to cover the apical half of the retromolar pad. We want to extend to the edge of the buccal shelf and then 1 millimeter short of the labial vestibule, avoiding the frena and the mentalis. And on the lingual, we want to follow the mylohyoid ridge in the posterior and then again stay about 1 millimeter above the lingual vestibule. And so if you make sure that all those features are captured and show up well, that will really help your laboratory to get a nice stable denture base for you. So let's talk about the analog workflow really quick, and then we'll talk about a couple different digital workflows, kind of full digital versus analog digital hybrids. So like I said, I'm going to give you kind of a brief overview. I'm sure most of you are familiar with this process, so I don't want to belabor this. So if you're doing a traditional 5-appointment denture, your first appointment would be to take a study model. Alginate are fine for this. You want to make sure either you pour them up yourself or that, or one of your staff members, or that your laboratory is able to get it right away so it's nice and stable. Once those are picked up in the laboratory, the lab will make a nice custom tray for you, and you'll capture the master impression. Make sure that the tray fits nicely, and again, that you capture all your anatomic features. You'll probably want to do border molding to get a good result, and you want to capture your posing impression at this time as well. Once you have the master impressions back in the laboratory, your laboratory will make bite blocks. Now, one of the things about bite blocks is that it's easy to think of them as just a tool for capturing the actual bite, but they're really more than that. You can think of them as a prototype for the setup. So if you sculpture, especially on the maxilla, the plane of occlusion and the incisal edge where it needs to be, the buccal so that it adequately supports the lip, the posterior extensions so that they are showing the correct tooth position, then your laboratory will follow that, and you'll find that your setups are much more predictable. Of course, it's helpful if you can mark the midline, the high smile line, and the cuspid eminences. Once you have everything shaped up, it's nice to cut some notches in the occlusal surface and then take some blue mousse or other bite material to capture the CR bite. As I was saying, the more you make the bite block where the teeth should be, the more predictable your setups are going to be. So then the laboratory will get the case back in the lab and articulate it, and then set your final denture teeth in wax based upon the guidance you've given them and the base plates. Your fourth appointment, you'll try the teeth in and you'll evaluate the aesthetics, occlusion, articulation, and phonetics. The teeth are set in wax, as you know, so the patient can't really function on it, so you have to be a little bit careful with it. And you also, there's the challenge of evaluating the fit. Most laboratories try to do the least amount of blockout they can on the denture bases, but usually there has to be a little bit. And so you kind of have to use your judgment as, does it fit well or not? If you're not 100% sure, probably the best thing to do is paint the base plate with some impression adhesive and go ahead and take a nice impression in there to send back to your laboratory. Better, this is your last opportunity to capture the mouth, and we want to make sure we get that. Whenever you're doing a try-in, it's nice to take a bite just so that we can dial it in and make sure we get a perfect occlusion on the final restoration. So then your lab will rearticulate, maybe make a model if necessary, and then process the denture. So finally, in the analog workflow, you can evaluate the fit of the prosthetic. This can be a fairly long appointment because you need to ensure, of course, that your denture is comfortable, border extensions are correct, and the occlusion is even in occlusion and in articulations. Sometimes it stinks, but you have to realign your brand new denture just because it's not fitting quite the way you want. The other thing that can be a challenge is even when our laboratories follow the correct procedures, there's quite a bit of force involved in injecting or packing a denture, and sometimes the teeth can move. And so it can be a little bit frustrating for you guys, I know, because you're like, well, the setup looked great, but the denture not so much. And so one of the challenges, somebody said this, one of the clinician told me this once, and I thought it was kind of a good thing. In some ways, each time you see the patient in the analog denture workflow, it's like starting over. You're not necessarily guaranteed that you're going to get continuity from each step onto the next just because of the nature of the case. I mean, oftentimes you do, but there's changes that can occur. So as you guys know, the current denture workflow was perfected in the 50s, and it can work seamlessly. Every once in a while, we get a case finished in these 5 appointments. However, if you do 5 45-minute appointment, you're oftentimes looking at $1,300 in office costs in addition to laboratory fees. At the current levels of insurance reimbursement, analog dentures just aren't profitable. And many times, as you guys know, that's just the beginning. You wind up doing extra try-in appointments, you wind up doing post-delivery adjustments, and you start adding up your time and you're like, why did I even do this? And it's really frustrating sometimes because you get a patient and they're like, oh, I don't want to bother the dentist. So they wait until they got an area that's severely ulcerated. And then you're like, okay, well, there's so much inflammation, I'm going to make an adjustment, but it's hard to know exactly how much to do. If you over adjust, then you're cutting down on your stability. So that can be a problem. As you guys also know, dentures are not teeth. If a patient has a very flat ridge, especially on the mandible, even a perfect denture is going to be unstable. If you've discussed this with the patient ahead of time and presented implants and those have been rejected and you have it documented, it's not a problem. But if we don't have those conversations, we don't document those conversations, that can be another point of contention. Tooth delamination is another potential issue in the analog process. As you guys know, the real teeth that we're going to be using are buried in wax. And after processing, the wax can work as a separating agent. So even though us laboratories boil everything out carefully and use a variety of different wax removal chemicals and put mechanical retention on the teeth, sometimes there's a little bit of wax left on them that can act as a separating agent and lead the teeth to coming out. Because of the pressures involved to try and make the acrylic as dense as possible, we can also move the teeth or break the teeth every once in a while. And that can be a frustration because you're like, well, I really like the setup, but I'm not so crazy about the finish. Also, dentures, even well-designed dentures, can break from material overload. As you guys know, the ISO standard for flexural strength of a denture base is 65 newtons, and premium analog resins match or exceed that number, but not by much most of the time. And then last but not least, there's lost dentures. You've done everything, you've gone through all these appointments, everything is good, and then patient calls and says, oh, I lost it, my dog ate it, who knows, all the stories you guys have heard. And you're like, holy smokes, now I get to climb the mountain again. How fun. So I think a lot of times because of all this, it's like, well, I don't want to do analog dentures in my practice. I'd sooner do things that are simpler. Patients like the results better, more predictable. So I think that's where digital workflows come in. So the first thing is the fit. As you guys know, acrylic resins have a curing shrinkage of 8%. Injection and things like that help a little bit, but from a microscopic perspective, a brand new denture really doesn't fit perfectly on the day of delivery. And you can see in the lower right-hand image the difference between a nicely packed denture and a printed denture, the green being the areas of contact. And the area of contact is really important because that fit is basically what determines the suction. The more intimate it is, the better stability the patient's going to have. As we mentioned, digital dentures are cured in 50 micron sections, so they can have a near perfect fit, which is really nice. And it's intrinsic to the process. You design it to fit to the model and you print it with a good printer, it just happens. You can also, one other interesting thing about digital dentures is that when you set the path of insertion, the technician can really work hard to minimize the undercut and do the absolute least amount of block out that's necessary. So it's an area where your technician's skill can really push up against the edge of what's possible more than with an analog blockout process, I would say. Digital dentures, some of them are made as one piece. And so obviously the teeth aren't going to delaminate because it's all one piece. But even for the ones that have the teeth and the denture base separate, there's never been any wax involved. And the way that they're placed in the denture base is similar to how you guys do direct composites. So they're bonded there and they're essentially become one piece. I've seen is that the best analog denture resins have a flexural strength, the pink stuff I'm talking about now, of 79 newtons. The new Lucitone digital print material has a flexural strength of 200 newtons. When you get this strength with the precise thickness control of digital denture bases, it's much less likely to break. They can also be more resistant to staining. Last but not least, you guys can save the files. So when the denture is done, you could ask your lab, hey, can you give me the files for the teeth and the base, or however your lab does it? And can you document what materials and shades were used? Because this is a rapidly evolving field. Over the next few years, probably your lab will find even better materials that are being used right now. So it'll be helpful for you. Like, let's say a denture gets lost or broken. You can say, oh, hey, I got the files here. It was whatever kind of denture it was. Can you guys remanufacture it for me? And you can rest assured that the piece you get back will be the same as you delivered to the patient. Digitally, the process has more continuity. So because there aren't those steps where the teeth can break out of the investment, or maybe the flask doesn't close all the way or whatever, you're going to tend to see, and I've talked to several clinicians who've told me this, much more consistency. You're not like, well, patients come in, I wonder what's going to happen. You're going to be like, well, I wanted to move the midline 1 millimeter and it'll be moved exactly 1 millimeter and it's going to look great. So, or it'll look good before and we went to finish and it'll be exactly the same. You'll find that you get a lot more consistency. So you're not wondering how things are going to go. The cases go according to plan. So let's talk about some of the digital denture workflows that are out there right now. There's a question about how do you mark the post-dam soft palate on the digital format. Depending on the scanner, sometimes you guys can scribe a mark on the impression, which can be helpful. It kind of depends on the case. Labs do post-dams on their maxillary dentures that are printed, and some don't, because the post-dam fundamentally is compensating for that 8% shrinkage. And so when the whole thing fits, you don't need to compensate for shrinkage. So you'll kind of want to work with your laboratory, but usually you'll be using a much less aggressive post-dam if you're doing one on digital dentures than you would with an analog denture. So I want to talk about workflows that we can use. And what I'll try to do is talk about like the first one, and I'll talk about how each of the other ones are different. So we're not going through the same steps over and over and over again. There is a way to do a digital denture from analog records, and we'll talk about that. And then you can do digital records for digital dentures. There are a couple different ways to do that. And then we'll talk a little bit about facial scanning and how that can get you down to a 2-appointment denture, if you'd like. Appointments when you're doing the analog digital workflow are the same as those for the analog denture we previously discussed. You can take a preliminary impression if you want and have a custom tray made, or directly take your master impression. You need to use your normal border molding procedures. The digital denture will have a very accurate fit to the model, but the variable will be the correspondence between the model and the mouth. So you really want to, because of the accuracy of the digital denture, you want to really focus on taking your time to get that nice result for the master impression. If you want to cut down on your appointments and still use an analog impression technique, you can take a mush bite at the time of doing your master impression. So first, of course, you'll need to determine the correct vertical dimension of occlusion and find a repeatable and measurable way to get that. Then you can get some 2-part dental putty, mix it up and place it on the ridge, adapting to the vestibules and the lingual or the palatal, depending as the case may be. You want the patient to close gently and stop them when they've reached the correct VDO. Sometimes you'll need to kind of adapt their face a little bit so the putty doesn't distend their lips, because the putty will kind of serve as the bite block. Again, you'll want to scribe all the marks we've talked about on there. You reline the mush bite with putty, it'll be even more helpful, or sorry, with impression material, it'll be even more helpful. And again, you can see in this case, person's taking a bite. Of course, you can also you can ask your lab to just make a bite block for you, and then you can try it in, you can reline it if you need to. So your procedure for the bite block could be the same if you choose to do that. Usually labs can print base plates, but we're finding, I think just because of limited printer capacity, sometimes it's easier to hand make the base plates in these situations and then flip to digital. So the next step is when things get quite different. So once you've taken that bite and sent it to your laboratory, your technician will articulate the case and then scan it at the bite you provided. They'll scan the master model, the opposing, and the bite block or mush bite as a guide for the tooth position. And then your laboratory can use that position of the bite block or the mush bite in 3-dimensional space in their design software to get the teeth in exactly the right position. Once the teeth are positioned properly for aesthetics and function, as we've talked about, the borders will be designed. And again, usually with less blockout or even no blockout compared to a base plate. And then usually the tooth and base files are merged to create a tooth-colored tri-indenture like this. It helps with the cost of it, and it also ensures the patient will be back to get the final. So when you try this in, it really changes the nature of your try-in appointment. Firstly, it's sturdy enough for the patient to wear. So if you want, you can tell them, hey, this is a prototype. Why don't you take it home, use it for a day or two, let me know what you think. You can also mark on it, grind on it, reline inside of it. So it's very sturdy. You can see in this photo, there's been some good information provided to the laboratory to be able to change the case. So not only can you make notes on your prescription, you can actually show the lab what changes you want on the prosthetic. Huge changes, you may want to do another try-in just to make sure that they've been done predictably. If you're making small changes like this, most of the time you can go straight to finish. So back in laboratory, your lab will scan that denture as a reference. If you've had to reline, your new model will be poured, scanned, and imported in that correct occlusal relationship. And then your lab will alter the design as necessary and digitally manufacture the case. Labs can do that in a variety of ways. They can use carded teeth that are specifically designed for digital dentures, or they can mill and print teeth. Milled or printed teeth tend to be a little bit easier to use because a lot of times, as you know, with denture patients, we don't have a ton of vertical space, and you can't grind carded denture teeth. You have to have enough space for them. So sometimes your lab will start setting it up and they'll be like, digitally, they'll be like, oh, I can't use these. So I think we're seeing mostly lab manufactured teeth today. And again, it's just like with you, each lab is going to have a workflow that works best for them. So do talk to your laboratory about the workflows that they use so that you guys can pick something that'll get you both the great results that you want. Once you get that final denture, you'll check the fit and bite, and sometimes it's nice to put some cotton rolls in there and have the person bite down for about 5 minutes just to help stabilize it. Most of the time, these appointments are going to go very quickly. Again, you know it fit because it fits the same as the try-in. The teeth haven't moved unless you ask for them to be moved because they're in the same position they were in the design. And so you're going to see much more consistency. Again, this appointment should be very fast for a digital denture, as opposed to, as we talked about, it can be very time consuming. And it usually won't be the beginning of a whole series of adjustments. Most people who use these find that adjustments are pretty rare. I know of one office that they used to schedule a recall appointment. Now they're like, call us if you have a problem, because it's like only once every blue moon when they actually have a patient who needs an adjustment. So that's if you want to start analog and flip to digital. What if you want to start digital and keep going digital? So one of the advantages of the latest generation of iOS systems is that they allow the possibility of taking an accurate and fairly rapid edentulous scan. Sometimes this can be difficult to do clinically, so you kind of have to decide what works in your practice. As you know, there's a lot of mobile tissue, and so you have to get the patient open enough so that you can scan the tissue, but you also want the vestibular position and different things like that to be where it needs to be for accurate borders. I think most people are doing what we'll call a reference denture workflow that we'll talk about, which is kind of a different kind of hybrid analog digital workflow. But if you want to do this procedure, you certainly can. As you guys know, scan path is the key to getting good, consistent results. So with dentate patients, it's a little bit easier because usually we scan the teeth as a stable point of reference, and then we add kind of data to that occlusal data. The first data set, we add more data to get the buccal lingual walls, etc. Italian prosthodontist Dr. LaRusso, shown above, has done a study and found that this is the most predictable way to scan for dentures. So, and again, as a good question before, you want to make sure you find a way to indicate on the scan where that vibrating line is, so your lab can extend the border correctly. Again, if you scan this, you'll either do a mush bite and scan it at the scan tissue appointment, or you'll do a bite block. Then from that point, the workflow will be the same as analog digital workflow that we just talked about. Next, and this is probably the most popular, is the reference denture workflow. 80 to 90% of your patients are going to have a denture. Some of them you're going to have to lean on pretty hard to get them to bring the denture. But what you can tell them is that your denture, I don't need to make the new denture anything like your existing denture, but I need something to capture your mouth that will save us both time so that you can get your denture more quickly. So if you bring your denture to your next appointment, we'll be able to use that as a way of taking an accurate registration of your mouth. Of course, this is the patient's denture. You want to be careful not to alter it during this process, but you will need to make sure you can capture all the data that's needed. So first, you'll look at your borders, and if there's any deficiencies like there was on this mandibular denture and the retromolar pad, you want to add a little bit of compound to support your impression. And then you'll do your border molding with your heavy body impression material. As you guys know, paint adhesive first, then syringe your heavy body around the borders. Hold the denture in place with your fingers and ask the patients to open and close while you're holding the denture, move the mandible from side to side, show their biggest Duchenne smile, and then pucker. For the mandible, you want the patient to pucker, show their Duchenne smile, then stick their tongue out and move it from side to side before closing and swallowing. Once the heavy body material is set, you'll apply a low viscosity material to the internal surface of the denture and go through all the border molding steps again. This is best to do with any impression situation. You know, if you're doing your custom tray or you're just starting with a a master impression at your first appointment. The more you do this, the more you know that you're giving your laboratory the best border information. The other thing that's nice about this is that you're capturing the borders where they need to be dynamically. One of the challenges with scanning with an iOS is that the vestibular tissue could be in the wrong position and it's hard to know. With this, the denture itself will force the tissue into the right position, or the tissue will, I guess you could say, will alter the impression material so that we know exactly where our border should be. So once you've done that impression reline, make sure it's nice and stable. You want to evaluate the aesthetics and you take some pictures. Us labs, we love pictures, and make notes. You want to take a bite. If the video is overclosed, no problem. Use your leaf gauge to open the bite, and then take a bite around your leaf gauge. So then you have a reline denture and a bite. So the first thing you'll want to do is you'll want to scan your whole reline denture with your iOS, both the intaglio surface and the external surface. So you've created a 3D registration of the reline denture. Then you'll scan the opposing arch or the opposing denture. You'll scan this extraorally. And then you'll place a reline denture or dentures in the person's mouth with the bite and scan both sides of the arch to digitally capture the bite. Again, you'll want to note any changes that need to be made and send the scans to your laboratory. You can remove the impression material and return the denture to your patient. It helps use a little bit of alcohol to clean that adhesive out. Are milling always better than printing? Good question. And we'll address it in just a minute, but what I would say is that with first generation printed materials, the milled materials were so much stronger that it was worth putting up with some of the problems that come with printing, with milling. But I would say with the second generation materials, I think printing, from a philosophical perspective, printing is always better than milling because you're just making what you need. You're not subtracting a bunch of stuff that basically wastes time to get to what you want. And there's a question about immediate digital workflows with immediate dentures, and I'll cover that in just a minute. I kind of got my normal stuff, and then I'll do kind of the one-off kind of things next. If your patient doesn't have a denture and you want to capture all your information on the at that first appointment, again, you can make a mush bite and then scan the mush bite to create your master impression. So you'll need to capture all the borders, do a reline inside of it, and then you'll scan the whole thing 360 like you would a denture, scan the opposing, scan the bite, and your lab can use that to mount the case. It's a more advanced workflow. It's going to take a little more time at the appointment, but it does eliminate that middle appointment. So you kind of have to look at your time and kind of decide what works best for you. If you don't have a denture and you're like, I don't want to do the mush bite thing, you can just take your reference dentures. You can just take an intraoral scan or an impression and then send that to your laboratory, get a bite block, and then reline the bite block and basically do the reference denture workflow with your reline bite block instead. All right, onwards and upwards here. So your lab will accept the case files, then design the new denture. This screenshot I think is kind of cool because it shows you guys how the data from the previous denture is the purple, and then you can see where the new teeth are. So your lab can look very precisely and see what changes do we need to make to get this denture where it needs to be. And if you want, you can get screenshots of this. These are easy to take, and your laboratory can share them with you so that you know what changes are being made. You can share them with your patient. So your first appointment is scanning the reference denture. Your second appointment will be the printed or milled try-in, and the third one will be delivery. So this gets you a good, solid procedure to get to a final denture in 3 appointments. Now I'll talk about a couple of kind of more unusual workflows, I guess I'd say. One of the things that I think is different between clinical dentistry and laboratory dentistry is that for you guys, you get to see the patients every day. And so you look at things and you're like, well, that doesn't look very good in the patient's mouth. But many times for us laboratories, we don't get to see the parts of the face that are really important for our teeth. We don't get to see the lips. We don't get to see the nose, the chin, the eyes. So you guys do your best to give us something that represents those things. So maybe you take a study model and we say, okay, well, these are teeth that look good for this patient. So if you copy it with these changes, it'll look good for them. Or you might contour bite block and you say, well, this will support the patient's face adequately if you do that. One of the cool things about new facial scanning technology is it's not a picture. It creates a three-dimensional, this here is a three-dimensional STL of the person's face. So I got them all turned facing towards you, but you can turn it any old way you want. You can look, from the inferior view, you can look at a lateral view, whatever you want. You're actually designing within the patient's face. So I think that with facial scanning and with correct alignment procedures, it allows us technicians, when we're designing the case, to actually see what you guys are seeing and design not to something that kind of looks good in the person's face, but actually put the teeth in the right position relative to the patient's face. So when you're doing facial scanning, with dentures, you use the reference denture workflow, then add your facial scans. Using your facial scanner, you scan the patient wearing the denture with retracted smile, Duchenne smile, normal smile, and relaxed lip. And then you send all those to the lab along with so you're sending a lot of files to the lab with your reference denture scans. Your laboratory will align everything, and then they'll actually do the design in the mouth. Well, you're like, cool, but who cares? So the design is scaled to the person's face. So you'll find pretty quickly that you don't really need to do physical try-ins with these cases, because you can show the patient and look at them yourself in like one of the free 3D viewers, like the one from ExoCAD, and see how's it look. And I'm sure when you do the first view, you'll be like, oh, this is kind of sci-fi. I want to actually see something. And of course, your laboratory can get you a try-in, but you'll see pretty quickly that what you saw in this image is exactly what you see with the final. So what this does is it allows you to get to use a reference denture and do a 2-appointment denture, basically your scan appointment and your delivery appointment. As far as I know, there's a question, does 3Shape program have the facial scanning feature? So if you get facial scans, you can align them because they're just STLs in 3Shape, but usually you need to, what am I trying to say? You need to get a separate facial scanner because it captures a much larger area than a traditional iOS. So right now, I don't know of any facial scanners that are also iOSs. So you'll be using your iOS for the reference denture scan, and then you'll be using a separate scanner to do the facial scan. With this process, you can predictably deliver exactly what the patient saw at the virtual try-in every time. And again, I'm showing you the facial view, but you can turn this however you want. It's just like any other three-dimensional model. So you can look at profile view and whatever. The more scans you get with different lip positions, as far as I know there's some research been done on dynamic facial scans, but I don't know of any that have been released commercially yet. But you'll be able to see whatever scans you take, then your laboratory can stack them all together and go from low lip to look at the incisal edge position to high lip, look at the buccal corridor, everything. I've seen a bunch of these cases delivered, and the intraoral photos, it's kind of funny because you'll look at the scan ahead of time, and then the doctor screws in the all-in-4 prosthetic, and you're like, holy smokes, it's just the same. If you turn the 3D view exactly the same way the patient is sitting in the chair, it looks exactly the same. So I think that there's going to come a day where we're like, well, this is goofy. I wonder why we ever did things without a facial scan. So I think this is going to make a huge difference in dentistry as we're moving forward. So here we get to the printing or milling thing. So I would say from a theoretical perspective, printing is better. 3D printing intrinsically has less waste and can work more quickly. But a couple of years ago, milling definitely had the edge. Milling is intrinsically more precise, and proven PMMA pucks available either in single shade or multi-shade gave the lab the ability to deliver a high-strength aesthetic denture. Really, the only limitations with milled dentures are the extreme undercuts you get sometimes in the anterior maxilla. and it takes a long time to mill a denture. I mean, it's not unusual to take 4 hours to mill a denture. So and it can be a little bit hard on your equipment because plastic, surprisingly, plastic is much harder on the mills than zirconia. So the first generation of 3D printed denture materials really couldn't match the strength and aesthetics of analog dentures. So it wasn't really the process that was the problem, but it was that the materials. Right now, we have printed materials that can meet or exceed the strength of the materials that we've seen in analog dentures. So I think that printing is kind of ready for prime time now. Again, I would talk to your laboratory. I can't say, your lab is going to do it this way. You want to talk to your lab again. You want to collaborate so that you guys are both you're both working in your sweet spot. You're working with the materials and techniques that work best for you so you can deliver the best results for your patient. But I would say from a theoretic perspective and where materials are, I would say printing has the edge. Copy dentures. If you have a patient who likes their denture or who mostly likes their denture and wants just a reline, you can either scan the original 360, send it to your lab and have them copy it, or you can do a reline, do a reference denture 360 scan and send that in. Most laboratory software does not have the equivalent of CEREC biocopy, where you push a button and it makes it exactly the same as preoperative teeth. So it will require some skill from the designer, and there may be slight variations. But again, you remember the image that we saw of the purple bite block in the teeth. Your laboratory can superimpose their teeth on the previous prosthetic to make sure it's right. It's good to know it's available. It may not be something you do a lot of, but it's out there for what it's worth. And then immediate dentures, we want to talk about that. So to do an immediate denture, you're going to just take a normal iOS scan. The main thing is that when you do your immediate denture, you need to capture the borders. You will have the teeth as a reference, which will help quite a bit. And then your lab can digitally extract the teeth and still make a copy. So we have the teeth that we can use for a guidance of our denture tooth position, but then we cut them off the model, so to speak, to actually make the base. The more guidance you give your laboratory about what changes you expect extractions, the closer they can get. Most of the time, if a lab were to ask me, I say just cut the teeth off at the free gingival margin. That will have the effect of giving you guys a little bit of space for a soft liner, because I feel like it's a heck of a lot easier to fill some space than it is to try and fit a denture on fresh extractions. What's cool about this is that then when the patient's healed, you can do the reference denture workflow for the using your immediate denture, reline it as your denture to take the reference scan. Last but not least, printed over dentures. Because printed dentures right now are very strong, there's some great strong materials. These can be very helpful for overdentures. I didn't want to try to cover the whole workflow here, but keep in mind that this can be another application for your printed dentures. With locators, they have these new scan bodies that are designed to create a perfect space inside the base so that you can easily loop the housings in the mouth final denture. Thank you very much for attending and for listening today. I enjoyed spending this time with you.